Hello, warriors and supporters. Welcome back to CWF Presents CRPS/RSD is Real. Before we get started, I just want to wish all the mothers a happy belated Mother's Day. I hope you had an awesome day this past weekend. I know I did. We are on episode 7 this week. We are very excited and honored to have with us today Dr. Damien Dauphinee. He is a board-certified reconstructive foot and ankle surgeon focused on peripheral nerve injury and pathology. He's located in Texas. He has a book published called Saving Limbs, Saving Lives. He has a podcast series called Pod Doctors, and he also belongs to the Association of Extremity Nerve Surgeons, through which he teaches workshops and trainings on peripheral nerve. So without any further ado, let's get into episode 7 and get to know Dr. Dauphinee. Danielle, floor is yours.
Thank you so much for joining us today. I greatly appreciate you taking the time out of your busy schedule to meet with us. I think it's a fantastic idea to have doctors of your caliber on. That way we can sort of discuss the finer details that are often left out of some of the workups around CRPS patients. There are too many doctors that are sort of afraid to touch CRPS patients because they don't even know where to start. So if you don't mind, can we start with a little bit of your background, maybe how you got into treating not just CRPS patients, but your specialty with foot and ankle surgery?
Sure. Yeah. So I have been a reconstructive foot and ankle surgeon for 25 years. I went to the University of Notre Dame for undergrad and then went to the Scholl College of Podiatric Medicine in Chicago, which is part of Rosalind Franklin University of Medicine and Science in Chicago. Then I did year residency in California and then 2 more years in St. Louis. And my original sort of intern year in California was spent attending named Nicholas Grumbine. And Dr. Grumbine treated a fair number of CRPS patients. Back then, we were still calling it RSD. He felt that you could address some of the contractures and the arthrofibrosis or the stiff joint aspect in some of those folks, that you could address that by putting them under anesthesia and manipulating their joints with them under anesthesia. And then he would do what's called a beer block, and he would put on essentially a blood pressure cuff, but we're talking lower extremity. So the blood pressure cuff would go on the leg, and they would infuse into the vein a cocktail of steroid and some components that they believed would help break up some of the scar tissue and the fibrosis. And I'm blanking on all the 4 or 5 components, but that part of it was kind of pushing the envelope at the time. He felt that you could get these people moving again, and if you could do that, you could help protect them from some of the repercussions of long-standing CRPS. And to what extent it worked, I was only there for a year. Basically, being able to be in contact with these patients and seeing how they would get diagnosed or almost labeled with this disease, and then everybody would stop looking for an answer. Like, is there some other component to this that we're missing? And so that's where I think the new nomenclature, the CRPS type 1 and type 2 nomenclature, is somewhat helpful because it helps distinguish between kind of 2 varieties. And the funny thing is, maybe in 20 years, we may find that this is part of some other complex disease state that we don't fully understand. And I think the likelihood of that is probably pretty good. But so my journey into doing peripheral nerve work came fairly early on in early 2000s. I was frustrated with treating diabetic peripheral neuropathy patients, trying to treat their pain with just gabapentin and then Lyrica. And that was it. It was like, okay, we're going to put you on this drug that makes you sleepy and loopy. It basically anesthetizes you until your nerves die. That's what we were doing because the drug wasn't fixing anything. And in a certain percentage of these patients, probably 30 or 40% of them, they're suffering from a nerve entrapment that is being brought on by metabolic problems with the nerve. So, and it's just, I don't want to go down this tangent too far, but in diabetic patients, their nerves are getting swollen. And that swelling is happening because of a breakdown constellation of things that happen with glucose when there's too much of it in your system. It gets broken down into something called the sorbitol pathway, and sorbitol gets into the nerve and causes fluid to follow it, and you get a swollen fat nerve. When you look at these nerves in the OR, they're like 2.5 times the normal size. They're huge. So
Wow.
if you get a nerve that's way too big for the tunnel it's got to go through, you have a problem. So these patients were being labeled with diabetic peripheral neuropathy. Everybody was stopping the investigation. They weren't looking for those patients that might be suffering from a nerve entrapment that we could fix surgically. So I'm treating these patients with gabapentin and Lyrica. I'm frustrated with that. And so I went and sought out a guy named Lee Dellon who had written a few papers on the subject of using nerve decompression surgery. In other words, like a carpal tunnel release. And the
Mm-hmm.
funny thing is, he's figured this out purely based on his carpal tunnel patients. He was operating on these diabetic patients with carpal tunnel and realizing that he could get rid of their pain, their sensation would improve, their grip strength would come back. And they would come back to him and say, Doc, you did such a great job on my hand. Can you fix my feet? They're killing me. And he would say, no, that's diabetic peripheral neuropathy. There's nothing we can do for that. So he was stuck in the dogma too. And it took about 5 or 6 years of hearing the same story over and over for him to kind of think, gosh, I wonder if this really is the same thing. So he went back and did rat studies and looked at the gait of diabetic rats. You can make rats become diabetic. You can do that. Well, I mean, just feed them enough food, they get fat, and they get
Right.
type 2 diabetes. And you could watch their gait patterns change as they became neuropathic, where they couldn't feel their feet anymore. And then he
Oh.
would go in and do a surgery where he would decompress their tarsal tunnel, so decompress the tibial nerve, which for rats is the same in us, it's the bottom of the foot. And he would watch their gait patterns normalize. So there was something to this, he realized. So he stopped telling his hand patients that there wasn't anything he could do for their feet, and he started operating on their lower extremities and decompressing the common fibular nerve and the tibial nerve and restoring sensation and improving their gait pattern because they had more balance now. Balance is purely based for most of us on sensory input into our peripheral and central nervous systems. So if you lose sensation, your balance is going to be shot. Well, these people were realizing that their balance was improving and their lives were improving. They had less pain, they had more sensation, they could stay out of trouble. They weren't the ones that were ending up with ulcers that would get infected. So having seen that happen and read his papers, I went and studied with him and did a course with him, spent time in the operating room with him, and realized he was really onto something. At that point, in the late 90s and early 2000s, he was an attending at Johns Hopkins, and he was labeled a heretic. The neurologists thought he was absolutely a wackadoo, and they said, "How can you tell us that you're fixing diabetic peripheral neuropathy?" And he says, "You're missing the point. I'm not fixing the disease that's causing the nerve changes. I'm simply fixing the problem that's causing the symptoms. But it's good enough. That's good enough. If we let the nerve swell, but it has nothing compressing it, it's going to still function relatively normal." And so he realized that pretty early on. It took him 30 years to prove it to people. In fact, one of the most recent studies on that particular type of neuropathy was just published in the Annals of Surgery this year. It was almost a 10-year study that was partially NIH supported, and they looked at both sides. They looked at surgical and non-surgical. They even did sham surgery, where they would operate on one side and not the other, and then follow the patient for 10 years. So anyway, all this is happening. In 2003, I take his course. I spend time in the OR with him, and my entire practice changed. It quickly became about 75 or 80% peripheral neuropathy, which was really cool because I was dealing with patients. I was managing a wound center and seeing the repercussions of the diabetic neuropathy when it got bad and what it would
Right.
do and cause ulcers and lead to infections and amputations. And I finally had a way of intervening before they ended up getting the ulcers. Or if they had their first ulcer, we could go and take them to the OR, decompress their nerves, and we would reduce their recurrence rate of new ulcers down to 3%.
Wow. That's
Typically,
insane.
it's 20 to 25% recurrence rate. So
Right.
we were able to make huge gains in the diabetic population. So the CRPS, my experience with CRPS patients back in California during residency was sort of dormant for a while. But once I really saw the power of doing the surgical nerve decompression on the diabetic patients. We started seeing patients who had chemotherapeutic-induced neuropathy, alcoholic neuropathy. The alcoholic neuropathy folks, unfortunately, they don't do that well with surgery. They seem to be sort of recalcitrant to that. But we started seeing the CRPS patients and then really looking at whether or not they had a true nerve entrapment component to this or a nerve injury that we could intervene in. Because sometimes you can't fix the nerve, sometimes you just have to take it out.
Right, absolutely. I think taking a quick step back, just so we can sort of explain to our listeners, I've personally had multiple back surgeries, and that's where my CRPS began. I completely compressed my sciatic nerve. I blew out a disc and it was completely crushed down my left side. So, what my surgeon at Barrow Neurological, which is basically the Johns Hopkins of the West Coast, at Barrow Neurological, the head of surgery explained it, and correct me if I'm wrong. A nerve is inside of a sheath. The sheath is like the straw, and the nerve is all the water that flows through the straw. It's just sort of in the center. That sheath protects it. Any normal body, nothing is touching that straw. So you won't feel nerve pain. The minute anything, even half of a millimeter, touches that nerve sheath, you're going to instantly feel pain. If it's compresses that straw, even in the slightest bit, is when you're going to get maybe drop foot or that burning sensation or numbness or drop foot is what, sorry, when you can't lift your foot, for those who don't know who are listening.
Right.
Or personally, I know that, some people can't lift their arm when they're having a nerve entrapment in the neck. So I think it's really important that people understand the tiniest touch of that nerve sheath creates a problem. You're talking about going in and releasing. What does that mean?
What the spine guys are doing is very similar. They're either removing bone that may be compressing the nerve, or they're dealing with the disc, removing the disc that could be bulging into the nerve. So you're simply, in the lower extremity, you're simply releasing tissues around the nerve that are causing the nerve to get squeezed. So fascia is like saran wrap around all our muscles. And there are points, tunnels, tight tunnels that are normal part of our anatomy in our lower extremities and upper extremities, the carpal tunnel being one, obviously, where in the carpal tunnel, the ligament over the median nerve is the problem. And so you can go in and release that ligament and give the nerve more room, instantly, and
So
the nerve can
essentially,
recover.
you're giving it a wider straw.
Absolutely. Yeah. I think the long-term effects of constant irritation on the nerve cause that wrap around the nerve, which is called the epineurium, to get thickened and scarred. And when that happens, things can really be difficult unless you go in and release that epineurium and free that up. So sometimes it's an actual internal nerve problem. Sometimes it's the things around the nerve that are causing the problem. And sometimes it's the things around the nerve causing enough of a problem with the nerve that the nerve gets scarred internally. And then you've got a whole nother path that you have to go down. So I think, yes, you're exactly right. But these nerve entrapment syndromes happen all over the body. The most common one that everybody knows about is carpal tunnel. But in the lower extremity, we have common fibular nerve at the knee, where the nerve crosses over the fibular neck, right below your knee.
Right.
We've got the tarsal tunnel, which is sort of the instep of the ankle, and that controls sensation and pain on the bottom of the foot. The common fibular nerve at the knee is sensory for the front of the calf and the top of the foot. But these are normal anatomic tunnels that our nerves have to go through. But if they get tight or if the nerve gets stretched, that's a real problem with traumatic induced CRPS. People may have an injury, they may sprain their ankle. The ankle sprain heals within 6 weeks, but then they get this weird nerve pain that lasts 6 months, 8 months, and it starts getting worse well after the original injury. So sometimes it's hard to remember, okay, I know I had this weird ankle sprain 6 months ago, but that healed up right away. Why am I having this nerve pain now? Well, that nerve has been stretched. And very commonly, it's a superficial fibular nerve on the front and side of the ankle. And that nerve's real susceptible whenever you do roll your ankle is the typical term for it. And so people can get CRPS from something as benign as that. And it's that nerve stretch that's the problem. Nerves do not like to get stretched.
So it's funny that you said that. I have to say, I was in a car accident and I got the Lisfranc injury
Oh, those are terrible.
where my toes stayed on the brake as I stood on the brake and the bottom of my foot went down.
Yeah.
So I stretched the entire arch of my foot.
Yeah.
A lot of football players will get this, or somebody, if they jump from a high height, they'll land on their toes and they'll stretch that. And that took forever to heal.
Yeah. Those are bad injuries.
Forever.
Mm-hmm.
And I thought, but I was just standing on the brake. Nothing happened.
Sometimes it's the foot folds under. So people will
Yes.
injure it going downstairs. Their foot will fold under. The rest of them goes over, and now
Oh,
you've really disrupted the ligaments at the Lisfranc joint.
yes.
Bad injuries, sometimes they require, primary fusion, where we just go and take the joints out, fuse those bones together, because those patients sometimes never do well. So
Right.
yeah,
I never
that's a tough
thought like
injury.
that could create that long-term
Oh, absolutely.
nerve pain. Oh, I'm so lucky.
Yeah. Yeah, that could
I
have
mean, I
been
have CRPS
another,
elsewhere.
right.
Yeah.
But that could have done it to you for sure. And
Yeah,
that's
but
not a benign injury. That's a bad one. Yeah,
oh,
for
and I
sure.
didn't know. I thought it's I healed. Okay, we're great. But thinking about it, something as simple as a minor car accident that somebody could think, okay, so my foot hurts just from this car accident. I sprained my foot or whatnot, hitting the brake. No, that could be something very serious and could cause CRPS in the long run. And they would never tie the two together.
That is it's a distinct problem that we see. And so that when patients come in and they have a history of an injury, and sometimes it's the opposite. Sometimes people are trying to draw one-to-one connections between events that have nothing to do with it. So plantar fasciitis, people who have heel pain like to do that. They say, I stepped on a rock like 5 years ago, and now I have plantar fasciitis. And I'm like, that's not how it works. No, you have a very chronic, very common problem called plantar fasciitis. It has zero to do with what happened 5 years ago. But
Right.
in the case of stretch injuries, car accidents where they may have missed an injury, those connections can be drawn pretty easily when you know the mechanism of injury. If you can kind of get an idea of what happened to that patient at that time, because stretch injuries, traction injuries are what they're called, of peripheral nerves are tough ones, and they can scar in poorly. They can require surgery. Sometimes we have to take the nerve out, literally excise the bad part of the nerve, and then graft it with cadaveric nerve. And the cadaveric nerve has no cells, so they washed out all the cells. It's just the internal architecture of the nerve. And that can be very helpful for any injuries where the gap is less than 70 millimeters, 7 centimeters. So another component of what I do is try to establish patients who have nerve injuries. If it's CRPS, then we think it's CRPS type 2 because they got a true nerve injury from some sort of traumatic incident, whether it's surgery, a car accident, they dropped the knife on their foot, they got stabbed, they got shot, whatever it
Mhm.
might be. We can sometimes take those branches out and replace them, and that can address their nerve pain quite effectively. So there's a lot of different things we can do. Sometimes we have to denervate. Sometimes we have to take nerves out, cap them, plug them into muscle, and give the patient numbness. It's one of the nicest things you can do for somebody who has 24/7, 365 peripheral nerve pain, burning, stabbing, shooting, is if you can establish that nerve is the problem. And the way we do that is with diagnostic blocks. So if I can, lay hands on the patient, palpate, figure out that I think let's just assume that it's that superficial fibular nerve on the front of the ankle. I can drop 2 cc's of local anesthetic right above where the main part of the problem is, block that nerve, and if they get sustained pain relief for 2 or 3 hours, and they're great. They can jump, they can run, they can do dance, they can whatever they want to do. That's the pain generator. That's CRPS type 2, potentially, if they were diagnosed with CRPS. It's simply a nerve injury.
Right.
We don't have to call that CRPS type 2, but that is simply a nerve injury that we can address either by reconstructing the nerve or we can take the nerve out. And those surgeries are really gratifying. I mean, to be able to take somebody who's been kicked around by the system, seen 14 different doctors, nobody has any idea what to do, and I can spend 5 minutes with them establish that that's the nerve, block the nerve, have them smiling in the office as they walk out the door. I mean, those are so much fun. Those are really
Right.
fun to do.
That's why you got into medicine, to see that change. I'm sure of it.
Yeah, I mean that's been the most. I mean, saving limbs from a diabetic standpoint, and then being able to help people who have chronic peripheral nerve pain, by far the two most gratifying things I get to do every day.
Absolutely. I think something for our listeners, sometimes they may not even realize that the foot pain that they're dealing with, or even the pain in their hands, is a peripheral neuropathy. I noticed I was digging my toes into the floor whenever I sat down because it would stop the tingling. And I didn't realize that that's not something you're supposed to live with. So if any of our listeners are
Yeah,
finding themselves grinding their feet into the floor to get the sensation to stop or be muted for just a few minutes, you might want to go get that checked out and ask about neuropathy. And is that the sensation that you're having? Get it checked out. It never hurts to ask.
absolutely. There's a group that I belong to called the Association of Extremity Nerve Surgeons,
Mhm.
and the website is aens.us. And so that group is full of guys like me, plastic surgeons and podiatric surgeons that do peripheral nerve work primarily. So that's a good place to start if you want to get more information. Find somebody who's in your area. They've got a physician finder on there. So yeah, I think that's a great place to start.
We'll put that address in the description of our podcast for today.
That'd be great.
Uh, that
Yeah.
way it's right there in front of everybody.
We
I
also do
wanted
a podcast. I don't know if you knew that.
I I did. I actually
Okay.
went and listened to a handful of episodes, including the one about CRPS that was a more recent one.
Yes,
Yes, I actually did. And we can also link that because I
that'd be great.
find them very, very substantial in the way that you explain things. I find them very intriguing because there are some things that may not affect me, but the more information I have, when I'm talking to other patients, I can hear it in their situation and say, I think you should look at these doctors. They may be able to help you, they may not, but it's somebody that you can go to, listen to their information, pull what you need from it, and figure out if they're a voice that you want to work with and trust. That's a four-letter word in the community of patients
Uh,
warriors, is
I'm sure.
trust with doctors.
Yeah, CRPS is something that most people run away from. You are
Yeah.
absolutely right because the patients are struggling, they're frustrated. We have very little, overall at our disposal for helping patients with CRPS. And I think when the patient's frustrated and the doctor's frustrated, that is a recipe for disaster with that relationship, for
It's a
sure.
slow crash,
Yes.
watching a train wreck happen slowly.
And so I think, we're pretty good at identifying who we think we can help and who we just can't. And so sometimes we refer people back to whoever was managing their pain. But man, it's just so sad. I know that there are, thousands and thousands of patients out there who've been labeled with CRPS and probably have a nerve injury that could be addressed, and they're not even aware that that's a possibility. So hopefully we'll
Absolutely.
get the word out that way.
You mentioned earlier discussion about nerve medication, gabapentin, Lyrica, and whatnot. And these are some of the most common nerve medications. And I
They're
find the more CRPS patients I talk with that are put on these, the more I'm discovering a lot of them have similar reactions, that they slow you down cognitively, and you're behind everybody else. Everybody else is joking around having a good time, and you're still processing what was said 10 seconds ago. Do you feel like that is common occurrence with
Oh yeah.
CRPS patients, or even patients that shouldn't be on something like that?
No, I don't think that's exclusive to CRPS patients at all.
Okay.
I think that's a common side effect of the drug. and
Oh.
and it's generally something that fades with time. So that's
Hmm.
why when you're dosing somebody with gabapentin, the way we start it, the way everybody should start it, is low dose, and you slowly titrate. You slowly raise that dose to match their symptoms where they can tolerate the side effects. And one of the side effects is mental fogginess. And that mental fog tends to fade the longer you're on the drug. So it's not something that will typically last forever. And that's why if you start somebody off on a therapeutic dose right off the bat, you're going to turn them into a zombie. They're going to hate the drug, and we call that burning the drug. So now you've just burned that drug for that patient. They don't want to use it anymore, and that's sad. So I have patients who've been burned. They hate the drug, but I'll really work hard to convince them, if you'll just give me a chance, let me start you on a low dose at bedtime where the mental fog shouldn't be a problem. It's probably not going to help your pain right away because the dose is so low, but I want to get you used to the drug again. And so we'll start off with 100 milligrams at bedtime and do that for a couple of weeks. Then we'll go up to 300, but the studies have shown, and this is coming from the pain management specialist at Stanford University, studies have shown that most patients don't get good pain relief from that drug until they've been titrated up to 1,800 milligrams a day. So if you're not taking 1,800 milligrams a day, you're not benefiting from the drug like you could be, but you have to go slow to get to that point. So most people, they get put on too high a dose initially, they hate it, or no one bothers to titrate it. They put them on 300 milligrams once a day, and they're on that for 5 years. If you don't adjust the dose, you'll never find that happy place for that patient. The maximum daily dose is about 3,600 milligrams a day. I have virtually none of my patients on that much, but at least you've got this big, broad spectrum of dosing schemes you can use. And my biggest problem with that drug is patients that get put on it on a dose that's not helpful and nobody bothers to titrate. And that's a huge mistake. And I think, unfortunately, a lot of primary care doctors don't know enough about how to use that drug to understand what needs to happen to get to a place where the patient benefits from it. The other interesting thing about that drug is that there are patients who do not absorb it. So if you get titrated up to 3,600 or 3,000 milligrams a day and you have no benefit and you don't have any of the side effects, then you are pooping it out. It isn't even getting through your gut. So those patients, we switch to Lyrica. Lyrica is absorbed in the duodenum, so a very specific part of your intestines. So it's absorbed differently. That's kind of the only reason I switch people from gabapentin to Lyrica, because Lyrica goes through your liver and becomes gabapentin. It's a prodrug. It's a little bit easier to dose because there are very few dosing schemes for it. And so that's why a lot of people liked it when it first came out. But you're not really necessarily going to benefit any more from that drug than you will gabapentin if the gabapentin is dosed correctly and titrated correctly. So I think the failure for most patients put on those drugs is nobody's titrating them correctly, and you're not fully giving gabapentin a good college try. So those are hopefully two little pearls that people can use with their discussions with their doctors who are prescribing that drug.
Absolutely, especially if the 1,800 milligrams and you're only starting off with 100, it could take a while to titrate up. And
Absolutely.
perhaps they're going too fast. Perhaps they don't want to give that sort of time. So they're like, hey, we're just going to jump in with both feet, but that doesn't do you any favors either.
No, it could really turn the patient off. There's another older drug called nortriptyline that we'll add sometimes at night. Nortriptyline is a tricyclic antidepressant, but we use it for the peripheral nerve sort of side effects, and that can be helpful. Were a few drugs that came out over the last 10 years that aren't on the market really anymore and aren't used very much anymore because of their side effect profile. But those are still sort of the go-tos. And if gabapentin is dosed correctly and titrated correctly, it can be really helpful. So what it's doing, what we think, again, this is the interesting thing about gabapentin is it was originally a seizure medication, but it was really kind of a crappy seizure medication. Nobody really used it for that. But they kind of by accident found out that it really helped people who had peripheral nerve pain. Right. So it's essentially it's sort of being used off label. I think one of the companies may have gotten a label added it for peripheral neuropathy, but essentially it was not used for that initially. It raises the threshold for the nerve to get irritable. So it makes it harder for the nerve to send those spontaneous action potentials to your brain. And so that's essentially what we think it's doing. So it stabilizes the nerve membrane and it prevents the nerve from being as irritable. So you can see why that would be helpful for CRPS patients, for people with peripheral neuropathy of all types. And so that's why it's used as much as it is. It's not a narcotic, it's not an opioid, so it's far less chance of addiction. I think there are some reports of certain types of addiction to it, but I think those are pretty rare. It's very safe. Again, you can't overdose on it. You just poop it out. For that reason, it doesn't seem to interact a lot with other medications too. So for that reason, it's very helpful and a good place to start.
With your specialty and what you work with, I imagine you can probably give us a couple of pointers about foot care and how important it is in people's overall health. I think most people think your back is the most important part of your body when it comes to your overall health, and I beg to
That's
differ.
why
I think it's
spine.
feet.
Well, that's why spine surgeons get paid so well. So
Right.
yeah,
But
they get paid the big bucks. But yeah, I agree with you. If your feet are painful, you're going to be miserable. A lot of there's an old mantra: if your feet hurt, the rest of you hurts. So
absolutely.
I think that the things that I see on a daily basis that people can make an impact with very easily are moisturization. If you let your skin get ratty and scaly and cracked and fissured, you're asking for trouble. So I think moisturizers when you get out of the shower are really important. And then, making good shoe gear choices. I'll probably get, blacklisted by the Hey Dudes and the Skechers people, but they make terrible shoes. And I shouldn't even say that because I should send them Christmas cards every year. They drive people into my office. I mean, they're developing business for me left and right. Any shoe that you can fold in half is generally going to be problematic. And if you're 20 years old and you have tremendous flexibility and there's nothing wrong with you, you can pretty much get away with anything. But as you get older into your 30s and 40s and 50s, and I'm 54, man, you can't wear shoes like that without having the repercussions. And so, I think I love, and I'll just throw out the names. I don't care. I'm not getting paid by any of these people. Hoka, Brooks, Saucony or Saucony. I think they make great shoes. These are manufacturers that New Balance is great too, that offer multiple widths, almost in every size. And, fitting shoes where you've got width options is really important because if you're trying to go bigger to get wider, that's a terrible way to fit shoes. So I'm generally, sending people to high-end running shoe stores because if you can keep the high-end runner who are kind of crazy, if you can keep them happy, you're going to keep the rest of us happy. So
Right.
that's my theory for why I send people to the high-end running stores. And you're going to spend anywhere from 100 to 150 bucks on a good pair of running shoes. But that's the type of shoe, even if you're just a walker, that's the type of shoe we generally recommend because they're more sophisticated. You're getting more for your money. Skechers, not so much. And then there's a whole generation of women who have been snowed into believing Easy Spirits are good shoes. And your
Oh,
grandma
goodness.
probably has them, right? Grandmas are always the ones that show up in the Easy Spirits. God,
Yes.
they're terrible. So
Yeah.
yeah, I'm gonna get blacklisted by all these companies, but I don't care. They just are bad shoes. And any shoe that they glued the sock liner in, you've either gone cheap and it's a $40 pair of shoes, or that's a manufacturer you want to avoid. You want to be able to take that all that thing in there is a sock liner. You want to be able to take that out, put in a good quality arch support, whether it's over the counter or custom is up to you. But that's my soapbox on the shoe gear mistakes that people are making. And I think getting professionally fit every 2 to 3 years is pretty important. The funny story about a ball player that played, I practiced in the Metroplex here in the Dallas area, and one of the Texas Rangers ball players was having great toe joint pain, and he was seen by all their orthopedic surgeons. No one could figure out what was wrong, and he finally went. I think he went on his own to go see a podiatrist, and the guy was looking at his feet and looking at his shoes, looking at his feet, his shoes, his feet, his shoes. He's like, dude, you're in the wrong size shoe. And remeasured him, realized he was wearing the same size that he was 30 something. He was wearing the same size shoe from when he was 17. So
Oh,
he's
goodness.
like a size and a half too small. So he's sticking his big burly, baseball player feet into the size and a half too small shoes, causing great toe joint pain.
Right.
And as soon as they fixed that and put him in a pair of orthotics, he was like having no pain at all. So, I joke that that's like classic. Even professional athletes are making bad shoe gear choices sometimes. So getting professionally
Yeah.
fit and getting measured every 2 to 3 years is going to catch those subtle changes because all of us are getting wider and longer as we get older. Our feet are
Right.
just gravity pulling on you is enough to cause that over time.
I think the custom orthotics or even over the counter, the arch support is extraordinarily important. One flat shoe can really destroy your gait for days to weeks. And once you stop walking properly, especially with peripheral neuropathy, no matter the cause of it, as you know, it'll set off a chain reaction all the way up the body. And
Yep.
all of a sudden, for a CRPS patient, we're in a flare up. We're stuck on the couch because we wore the wrong shoe choice
Yeah, it can
for a
happen.
day.
Yeah. And, with our patients, we try to get them to utilize their running shoes as much as possible, understanding that some people have to wear dress shoes to work. And so we just get them to be kind of militaristic about, before work, after work, on the weekends, running errands, make good shoe choices. Use your running shoes with your orthotics. I'm a big believer in orthotics. I think they can be really helpful. Over-the-counter orthotics can be helpful for some people, but for most of the stuff I treat, it's really only helpful about maybe 25% of the time. So, we let people go down that road if they want to try that first. But if we give it 6 or 8 weeks and they're not getting better, then we try to get them back into the custom ones because they just work better. I mean, they just do.
Absolutely. I think that's probably the one thing I get on people about when they're wearing the little tiny thin flats,
Mm-hmm.
the little sandals, and you're wearing those all summer. It's like, oh, you're going to regret that in, I don't know, 10 years, 5 years. I
That's
remember when I used to work retail and I'd look at these girls going, oh, no.
Yep. I'm fortunate. I get to wear running shoes and pajamas to work every day because I wear scrubs every day. So I got a great job. Any place you can go, any place they can pay
Right,
you to be in pajamas and running shoes all day, you better be comfortable.
right. That's a good way to put it. What
Yep.
better reason to be a doctor?
Yeah, absolutely.
What is the number one thing that you think CRPS patients could bring to a doctor's appointment to help bridge that trust gap?
I think bringing a good history, bringing medical records is helpful. And honestly, I'll be honest with you, if this is a first time visit and you can get them to the doctor beforehand so they can spend time reviewing them, people don't realize that's really helpful. I have the same problem when patients come in with a MRI. There could be 200 different films on this MRI disc. If I
Mm-hmm.
have that ahead of time, I can really spend some time and go through each film. It's really hard, and they want an answer right away. So it's really hard during the 15 or 20-minute visit to do that. With our CRPS patients, our new patients, maybe it's a 25 or 30-minute visit. But if we can get some of that history ahead of time, it's great. So if your doctor, whoever was treating you, pain management, whoever, if they can transmit those records beforehand, that's great. Because I do honestly spend time going through that stuff. At the visit, if I'm handed a stack of papers like this, it's a little harder to do. So I usually say, well, let's meet again in a couple of weeks. Give me a chance to go through this. But there's not a whole lot I can do, without some time. So that's one thing. Keep in mind. Also, keep an open mind. I mean, you may have been labeled with CRPS. You think it's type 1, but maybe it is type 2. Maybe there is a nerve entrapment that we need to identify. And so that's where the diagnostic blocks are really helpful. So if I can do a physical exam, determine that I think you might have one particular nerve branch that's the problem, and block it, then that's helpful. If I'm torn between two neighboring branches, superficial fibular nerve and the sural nerve, they're next door to each other. Sometimes we have to bring you back and block one nerve one visit and then block another nerve another visit to be able to
Mm-hmm.
tell. So let's say I block the superficial fibular and the patient comes back and they say, well, it was like 80% better for a couple hours. Well, then we'll block both. And if they're like, hey, 100%, then we know the likelihood is that both those branches are involved. So that can be really helpful. I think understanding that if it's a joint related problem, sometimes we can take those nerves out that are innervating those joints. We can make those painful joints numb. And so that's an option for some folks. I think just having an open mind, maybe having some grace and allowing the doctor to maybe repeat things you think didn't work the first time. I think there's benefit to the way we approach things, and our success rate's pretty high. So if you had something done before and it didn't work, well, maybe it didn't work because it wasn't used in the constellation of the other things that I'm going to recommend. We also like to use, nerve supplements. I think neuropathy supplements can be a really good adjunct. So things like combinations of B6, B12, alpha lipoic acid, vitamin D. Vitamin D is a hormone. It's not just a vitamin, and it's a really important component in your peripheral nerve health. So, we get people on D, we get people on neuropathy supplements that can help upregulate the way their peripheral nervous system's functioning. And when you combine that with gabapentin at the right dose, and you combine that with some physical therapy, you can really make some inroads. I'm not just talking surgery. And then the patients that we do think are good surgical candidates, we try to work them up as completely as possible to make sure that we're not making this worse. The other thing that I think is important to note is that if you are talking to a peripheral nerve surgeon who wants to operate on you, thinks they can help you, it's a good idea to ask them, okay, what protocol do you use from an anesthesia standpoint that isn't going to cause my CRPS to go completely haywire? Because you are going to be injuring me in a controlled fashion. Surgery is, it's an injury, whether we like it or not. So we use protocols that, again, were developed by the anesthesia, pain management anesthesiologists out at Stanford. And so what we try to do is get people on 600 milligrams of gabapentin and 200 milligrams of Celebrex, unless they're sulfur allergic, 2 hours before the surgery. And then the anesthetic of choice is often ketamine. And why ketamine? Ketamine is typically used in peds for anesthesia. It's a dissociative anesthetic. So it's separating the experience of pain from the pain, which is really helpful, obviously, for people who are having chronic peripheral nerve pain. And then the other thing we do is we do nerve blocks. We'll do a popliteal block behind the knee that will make the whole limb numb. And we'll use long-acting anesthetics so that we can hopefully, when we decompress nerves in these patients, keep them numb for 2 or 3 days so that their nervous system wakes up slowly. And when you can decompress and eliminate the entrapment component in these patients and then have the nervous system wake up slowly, you can toggle off pain like you wouldn't believe. And so that combined with the ketamine, the pre anesthesia with the gabapentin and the Celebrex, it's very, very rare that we instigate a CRPS flare in patients who are having surgery. Even if they're having a bunion, even if they're having a bunion surgery or a hammer toe surgery, and they have a history of CRPS, that's our protocol so that we don't cause a flare in those folks. And we also work really closely with their pain management folks. I want to make sure that we touch base with them to make sure we're on the same page. If they're going to need narcotics, opioids for pain relief, are they going to prescribe them? Do they want us to prescribe them? We try to work all that stuff out ahead. I hope that answers your question. That's kind of those are the things.
Absolutely. Absolutely, it does. I actually recommend whenever somebody asks me for advice if they're going in for surgery with CRPS, I always tell them talk to the anesthesiologist before your surgery day and discuss with them using ketamine. And the
Yeah.
simplest way I explain is the ketamine sort of goes into your system and puts everything to sleep
Yeah.
in a different way.
It
And
does.
that way the CRPS doesn't jump. It sort of turns out the lights in the nervous system for a second.
And I would say over the last 25 years, found that there are anesthesia folks, whether it's CRNAs or MD, DO anesthesiologists, who are comfortable using ketamine, and then there are a few that aren't. And so you really want to know that up front. Is your anesthesia provider going to be comfortable delivering ketamine? I would say that may be a bias I have from way back when. I think in 2024, I seem to have run into far fewer anesthesia folks who are less than thrilled when I say, hey, can we use ketamine on this case? I honestly haven't had anybody give me any pushback lately. So that may be issues from long ago, but definitely a conversation you want to have with your anesthesiologist if you have a history of CRPS for sure. Can you use ketamine?
Yeah. And I think that's something that a lot of CRPS patients have to proactively investigate is to not just know your surgeon. You have to know who's giving you anesthesia.
Yeah,
you have to
absolutely.
know your whole surgical team and let them all know that you're a CRPS patient. And if they don't know what it is, then it's probably a good idea to talk to them about it or find somebody who does know what it is,
Right.
and keep them in your orbit.
Absolutely.
So,
yeah, I think you have to be your own best advocate.
absolutely.
Yeah. The last thing we want to do, fixing a bunion or a hammer toe is send somebody into a CRPS flare. That's that's bad form on our part. So we don't want to let that happen. Oftentimes it's out of your control. You've done all these things and maybe you cause a flare anyway. But man, if you do those things that we just mentioned, I think it's very unlikely.
Absolutely, absolutely. And I think based on what you were saying earlier, the one thing you want to do is see them happy and dancing out of your office
Oh yeah,
rather than coming back and saying, I'm in worse condition.
yeah. If you can get somebody to smile who's been in chronic peripheral nerve pain for months or years, it's great. It's really gratifying for sure.
Again, thank you so much for joining us today. I really appreciate it. We have so much good information. I would love to have you back again sometime soon, and we get to discuss more
I'd love it.
more topics.
If you get feedback from your listeners and from the warriors,
Mhm.
and they want to know, maybe we didn't get deep enough into a particular subject, that's great. I would love to do maybe a deeper dive on X, Y, and Z. So yeah, so if you get some feedback on this where we didn't go deep enough into something, let's come back and do another one for sure.
Absolutely. I would love that. And I know that many of our listeners, or many of the warriors themselves, have questions.
Thank you so much for taking the time out today to share so much information that will be so beneficial for many people that are listening. And I also wanted to thank you for the many resources that you provided for us and our warriors today. It really gives us a place to start when we don't have any idea where to start. The links are in the description of this podcast episode. The links for getting in contact with Dr. Dauphinee, the link to his podcast, and also the link to the Association of Extremity Nerve Surgeons, where you can start if you are looking for somebody in this field in your local area. If any of our listeners would like to support the podcast or the foundation, you can do so by texting CWF Podcast to 53555. Also a reminder that every Friday is Warrior Route 66 Challenge check-in day, so if you want to know where our warriors are at and how they're doing, check in on our social media on Fridays. And we also have an exciting opportunity for warriors. Dr. Chimbaga is hosting a research study for nanobead treatment on CRPS warriors. So if that's something that you would be interested in and you're located in the Southern California area, please visit our website to find out how you can participate in this study. If you would like to know more about the treatment itself, check out episode 5 with Dr. Chimbaga, in which she talks about this in great depth and length. Join us again on the 1st. We will be talking with Kyle Hartfield about TMS treatment.